Thank you so much, everyone, again for attending the first of our new series of webinars, Ask the Experts. Today, we'll be talking about gynecological sarcomas. I want to thank Dr. Matt Hemming, who is joining us today, and we'll go over some quick information giving the basics about GYN sarcoma, and then we'll get right into answering questions. Dr. Hemming, on to you.
Thanks, Liza. Thanks for the introduction, and very glad to join and join the community here. And I've got some slides to share, but just to highlight my role in patient care and research. So I'm a medical oncologist, meaning that I'm a cancer doctor that sees patients specifically diagnosed with sarcoma, and I'm part of a larger treatment team, but my focus is on surveillance, chemotherapy, getting to the right diagnosis, and then coordinate care together with radiation oncologists, surgical oncologists, pathologists, radiologists, interventional radiologists, and really a large team to provide comprehensive cancer care. In addition to my role as a sarcoma clinician, I also run a laboratory where our entire focus is sarcoma, trying to find some of the basic underpinnings of what drives sarcoma, different sarcoma subtypes, and new treatment strategies. So as part of the meeting today, we put together a couple of slides. Let me go ahead and share. Just to start with an overview and then to dive into some of the excellent questions that were shared ahead of time. So do the slides look okay, Liza? Everything sharing?
Yep, you're good to go.
Thank you. So first, as a broad overview, sarcomas are unlike any other cancer subtype in their rarity, their diversity, and how little we understand about them. Though collectively all sarcomas represent just 1% of adult cancers, there's more than 100 different subtypes. So managing sarcomas and thinking about sarcomas clinically can become very complex quite quickly. One strategy that I use to help categorize sarcomas in my mind is thinking about sarcomas that have simple genomes. So this is a plot looking on chromosomes. There's 23 pairs of chromosomes in all of our cells, and looking at the number of copies of segments of the chromosomes. And this is an example of a sarcoma with a simple genome. So there's few deletions or amplifications of different parts of the genome. And about half of sarcomas have simple genomes. And roughly the other half have very complex karyotypes. And what that means is there's a lot of dysfunction in the genome. There's some areas like over here in this case where there's a lot of amplification of part of a chromosome, whereas over here there's a lot of deletion of that part of the chromosome. And this strategy for categorizing sarcomas really helps to distinguish some that have really activation of one gene or a translocation, which happens in some gynecologic sarcomas as well. And a translocation occurs when two genes that are normally on different chromosomes or different parts of one chromosome, those genes break and fuse back together. And that fusion process creates a new gene that drives the cancer to grow. I won't go through any of these diagnoses in particular, but these are all different subtypes of sarcoma that have some very difficult to pronounce names. And here's a list of complex karyotype sarcomas, and these are much more difficult to understand where they come from and what drives them to grow. And clearly much more research is needed to understand this class. So for an overview of gynecologic sarcomas, roughly there's about 115,000 gynecologic carcinomas diagnosed annually in the US, and that is distinct from a gynecologic sarcoma, which is the minority of tumors in the gynecologic tract and about 2% or less of all cases. And this is a helpful distinction of carcinoma versus sarcoma. Carcinomas are the most common forms of cancer. Generally, they arise from cells and tissues that represent the lining of organs. So could come from skin, the lining of the gastrointestinal tract, the lining of the lungs and the airways, the lining of the gynecologic tract. And because those cells typically divide and turn over a lot and are exposed to anything that we eat or inhale or the environment, generally those tissues are at higher risk for forming cancer. Whereas in distinction, sarcomas, which are derived from cells that normally make up bone, muscle, connective tissue, they're not directly exposed to the outside world, and they also don't grow and divide quite as much. So that is kind of teleologically why they're so uncommon. and a clear distinction between these two different classes of cancers. Because sarcomas are so rare, as I've pointed out, it is essential to have your or a family member or anyone's tumors reviewed by a sarcoma pathologist. And getting the diagnosis is really key to finding the right treatment. In thinking about gynecologic sarcomas, leiomyosarcoma is far and away the most common, about 60% of gynecologic sarcomas. And this is followed by endometrial stromal sarcoma, which is roughly 20% of gynecologic sarcomas. And other sarcoma subtypes are fairly rare. Here's a few examples of incidence. So as I'd mentioned, leiomyosarcoma is about 60% of sarcoma diagnoses in the gynecologic tract. And this translates to about 6 cases per 1 million women. Whereas endometrial stromal sarcoma, as I said, about 20% of sarcomas of the gynecologic tract, and maybe there's less than 3 cases per million. A few other subtypes, adenosarcoma is about 5% of gynecologic sarcomas, and then malignant picomas, there's about 100 cases worldwide per year. So it ranges from something that is relatively common in the sarcoma world, but uncommon thinking of cancer globally, to something like picoma that is vanishingly rare. I'll highlight that education and advocacy are so important for rare cancers, for patients, for research, for clinical trials, and that important to look for institutional support, foundations like OKRA, and looking for information from guidelines and clinical trials from established resources like the NCCN or ESMO guidelines or OKRA guidelines as well.
And I just put the NCCN guidelines that OCRA sponsors in the chat. So if anyone's interested, they're welcome to click and look through.
I thought it'd be helpful to go through different sarcoma subtypes, some features that help with their diagnosis, broad brushstrokes on treatment considerations and prognosis, and separating these by different sarcoma subtypes. So first would be the uterine leiomyosarcoma is the most common sarcoma of the gynecologic tract. When a pathologist makes a diagnosis of leiomyosarcoma, there's not one specific test that gets them there. It's kind of looking at the cells through the microscope, doing a few tests, and having a gestalt that this is a leiomyosarcoma. So when a pathologist looks under the microscope at a leiomyosarcoma, typically they're spindle cells. That's just how they're shaped. They're kind of long-shaped cells, which is different from how carcinomas look. And they have some abnormal features in them. That's called atypia. Mitoses, and that's cell divisions, and tumor necrosis, meaning that there's some areas of the tumor that is dying as it's actively growing overall. They also do some specialized stains called immunohistochemistry, or IHC. And IHC stains that can support the diagnosis of leiomyosarcoma are Desmond, smooth muscle actin, and Cal-Desmon. And then sometimes we do genetic testing on these tumors, and characteristically, they have complex karyotypes and loss of tumor suppressor genes. And tumor suppressor genes are normally responsible for putting the brakes on a cell's growth. And cancers, leiomyosarcoma is classic for doing this, deletes or mutates the tumor suppressor genes so that the cancer cells can't stop themselves from growing. In thinking about treatment for uterine leiomyosarcoma, for localized disease, the primary approach is resection without morcellation. Morcellation is a process where in some procedures, this isn't done very commonly anymore, but to facilitate removal of the uterus or a presumed fibroid, the tumor can be broken up within the abdomen before it's removed. That can spread cancer potentially. So the standard is to certainly avoid morcellation if there's concern for any sarcoma. There can be considerations for neoadjuvant or adjuvant chemotherapy. That means giving chemotherapy before surgery or after surgery. And then in consultation with a radiation oncologist, we also consider giving radiation before or after surgery. And there's not strong data and not clear guidelines on when and how best to use chemotherapy in the neoadjuvant or adjuvant setting for leiomyosarcoma, in part because these are very rare diseases. So often we individualize treatment for each patient and have a multidisciplinary review of care to come up with the best treatment strategy for an individual. For leiomyosarcoma patients with advanced disease, traditional forms of chemotherapy have shown some benefit in leiomyosarcoma, and clinical trials are always something to consider. The prognosis, and again, I'm being quite broad here, is quite variable with leiomyosarcoma. with some tumors being quite indolent, meaning that they don't grow aggressively and their chances of coming back if they're surgically removed are low, to other disease which is highly aggressive and has a high risk of local recurrence and metastatic spread. The next gynecologic sarcoma to review is a low-grade endometrial stromal sarcoma. And the pathologist under the microscope sees more bland, less active cells that look more like the connective tissue within the endometrium. And typically, there's some specific markers they look for: CD10, the estrogen receptor, and the progesterone receptor. And unlike leiomyosarcoma, low-grade ESS is one of the cancers that is characterized by a translocation. So in the most common case, though there are a few others, two genes, JAZF1 and SUS12, are abnormally connected together. And that makes a new gene that nature never intended. And that the protein derived from that gene is what is driving these cancer cells to grow. For treatment of localized disease, typically there's resection of the tumor with consideration of hormonal therapy given after surgery. And for advanced disease, sometimes aggressive surgery is still considered, as well as hormonal therapy. And this low-grade disease often has an indolent course, meaning that even with metastatic spread of this cancer, it is slowly growing, and people can do well for a very long time with advanced disease. And compare this to high-grade endometrial stromal sarcoma. So contrasting features here is that tumor cells look more aggressive, meaning there's more evidence of growth. There's more atypia or abnormal looking cells. There can be more necrosis in this type of disease. A distinguishing feature for high-grade ESS is the expression of the cyclin D1 protein, which pathologists will stain for. And then the genetics is also driven by an abnormal translocation. The two common families are the YWHAE gene fusing to the NUTM2 gene, or other fusions involving B-core. And again, these generate an abnormal gene that nature never intended that more aggressively drives these cells to grow and form cancers. For localized disease, there's resection, much like leiomyosarcoma, resection with consideration of giving chemotherapy and radiation before or after surgery, depending on the patient. And for advanced disease, chemotherapy is the standard. And there's some evidence that doxorubicin can be particularly helpful, especially with this translocation. And the prognosis for high-grade disease, this is typically very aggressive, and many patients initially present and are diagnosed with advanced disease, making this a much more challenging disease to control and to cure. The next gynecologic sarcoma is undifferentiated uterine sarcoma, and fairly uncommon. The pathologist will recognize pleomorphic cells, and this is a diagnosis of exclusion. So many of the specialized studies that a pathologist would do to help make the other sarcoma diagnoses are negative or not helpful in this case. And then this is kind of a wastebasket diagnosis if they can't find a more appropriate term to call this tumor. And these can be aggressive, so management is much like leiomyosarcoma. Resection of the tumor for localized disease with consideration of chemotherapy and radiation before or after surgery, and that's a very individualized, multidisciplinary discussion with much input on the interests and values and preferences of the patient. And for advanced disease, chemotherapy and clinical trials. And again, this can be a very aggressive disease, and many patients present with advanced disease. There's two biphasic gynecologic sarcomas. One is adenosarcoma, and biphasic means that there's an epithelial or kind of a carcinoma component and a sarcoma component. And adenosarcomas are the one that are, at least as we think of them now, more firmly sitting on the sarcoma side of that coin. And the pathologist will recognize that these can be ER positive. The pathologist will also look for something called sarcomatous overgrowth. So if there is an abundance of more atypical, aggressive-looking sarcoma cells, they would categorize this as adenosarcoma with sarcomatous overgrowth, which portends a more aggressive disease. And treatment of localized disease, again, is resection with consideration of adjuvant hormonal therapy if there's ER positivity, possibly radiation. For advanced disease, hormonal therapy, chemotherapy, consideration of clinical trials. And adenosarcomas can be more indolent. The finding of sarcomatous overgrowth does portend a more aggressive course. The other biphasic tumor is a carcinosarcoma. And these are typically managed by the gynecologic oncologists and not me as a sarcoma medical oncologist. Another term for carcinosarcoma is a malignant mixed Mullerian tumor. And again, these are biphasic tumors. They're notable for sometimes having HER2 staining, and there are some therapies that we have that can target HER2. And then these are often aggressive forms of cancer, but again, since they're not sarcomas, I typically don't manage them and rely on my gynecologic oncologist to lead the medical therapy for these patients. The last gynecologic sarcoma that I'll highlight in detail is a PEComa, or perivascular epithelioid cell tumor. And these are recognized as having epithelioid cells, and they're considered to have more malignant potential if there's a high mitotic rate, if there's evidence of necrosis or tumor death within the specimen, if there's evidence of vascular invasion, so tumor cells getting into the blood vessels, if they're at large size, and other features that look high grade. And malignant PEComas are the ones that we worry about for spread. Curiously, this tumor subtype can express markers that look like a melanoma or melanocyte, as well as smooth muscle markers. So these can be very difficult to distinguish between leiomyosarcoma, and sometimes melanoma can be misdiagnosed, or PEComa can be misdiagnosed as a melanoma as well. The genetics of this are commonly loss of a specific tumor suppressor, the TSC1 or 2 gene. And in about 10% of cases, these will be driven by a translocation, not unlike the endometrial stromal sarcomas, but this translocation involves a different gene, TFE3. For treatment, most PEComas that are not malignant are cured by resection. For advanced disease, we treat with an mTOR inhibitor, a class of therapies that targets the loss of TSC1 and 2 in this disease. And there is one therapy that's specifically approved for malignant PEComa, and that's nab-sirolimus, which is an mTOR inhibitor. And as I mentioned, most PEComas are indolent and can be cured surgically, but a subset do have malignant potential, and that's highlighted by these risk factors here, and can be aggressive. Two other rare gynecologic sarcoma subtypes to mention but are very uncommonly seen is rhabdomyosarcoma, and that's commonly in the pediatric population. And then a uterine tumor resembling ovarian sex cord tumor is a pathologic diagnosis, but an extremely rare form of gynecologic sarcoma. So that's a overview in some detail for the most common gynecologic sarcomas. And I thought, since there were several questions on prognosis, just to highlight what the American Cancer Society has on their website for prognosis. And this is looking at 5-year survival rates for gynecologic sarcomas. And it's always difficult for any individual to think or talk about prognosis because there's a lot of variability, even with benign or aggressive tumors. And it's difficult with any one conversation to give a precise number, but it's helpful, and everyone's curious and wants to know what some of the longer term outcomes are. So I brought this from the ACS website, and again, this is 5-year survival. And for patients with leiomyosarcoma, they're stratified by localized disease, disease with regional spread, and then distant metastases. And the 5-year survival, as you can appreciate, with more advanced disease is worse. So 13% with patients that have advanced disease, metastatic disease. And undifferentiated sarcomas also follow a similar pattern, and that's true for some of the other sarcomas that we looked at that are more aggressive. And then contrast this to low-grade endometrial stromal sarcoma, where even in advanced disease, most patients can do well for a long time, either on observation or with therapy, in this case, for example, hormonal therapy. So I've mentioned clinical trials a few times, and OCRA has a lot of information on their website about clinical trials and a lot of support to find them. But I'll just highlight that in addition to that support, you can look at clinicaltrials.gov as a resource for completed, active recruiting clinical trials, and search based on keywords, based on the diagnosis of interest or a drug of interest, and see if there's a specific trial out there that you or a loved one might be eligible for. And contact your cancer center and your local sarcoma expert to see what they know about forthcoming clinical trials or what might be available close to home. Currently, there's a number of leiomyosarcoma or uterine leiomyosarcoma specific clinical trials. Other gynecologic sarcomas rarely have specific studies because they're so rare. And not uncommonly, for patients with sarcoma, Many are eligible for early phase clinical trials, and these are for therapies that are at their first testing in humans and are enrolling patients that have cancers that have no other standard of care or have gone through those standards of care. And this is where many sarcoma patients are able to find clinical trials. I wanted just to highlight a little bit of the research that we're doing and how we're using this research to come up with new ideas to treat sarcomas. And this is highlighting leiomyosarcoma. And again, leiomyosarcoma is the most common sarcoma of the gynecologic tract. And a challenge in sarcoma is because there's so many of them and they're so rare, we don't have good laboratory models to study them. And this is very true of leiomyosarcoma. So our effort in this study, and these are the names of all the collaborative group that worked on this project together, but we wanted to generate new models that were patient-derived xenografts. And what that means is out of the dozens and dozens of resection samples that we got, so a patient consented for a research study, we were able to obtain a viable tumor right after their surgery. And after the pathologist had completed their work in reviewing the tumor, we were able to take a sample for research and implanted that sample of the patient's tumor into an immunocompromised mouse. And that allows the tumor to grow inside that mouse as it would in the patient that it was derived from. So we developed a number of these patient-derived xenograft lines, and we're able to characterize them in various ways. And many of these came from the uterus, the uterine leiomyosarcoma or extrauterine leiomyosarcoma. And we were able to characterize them by looking at their gene expression profile. We did genomic testing of all of these to characterize the tumor suppressor loss and look at the tumor mutational burden. And some of these patients had sarcoma predisposition syndrome, such as Li-Fraumeni syndrome, or had tumors with unusual alterations, such as an ALK translocation in one patient. And not to go into too many details of the study, it's available free online, but wanted to highlight that this is one of the models that we made. So this is what a pathologist sees when they look at a patient sample. This is looking directly under the microscope after doing some simple stain on the tumor and doing some specialized studies. I'd mentioned smooth muscle actin and Desmond commonly stain positive in leiomyosarcoma. So this is what the pathologist would see. And after implanting these tumors in a genetically engineered mouse, the tumors continue to grow and they look just the same as the tumors they were derived from. So under the microscope, they look the same. We look at their genetics and how their genome is changing over time, and it doesn't change while it's growing in these mice. And how they're controlling their gene expression doesn't change while the tumors are growing in in mice. So these have turned out to be an excellent source of a model to study leiomyosarcoma in the laboratory. And some of the things that we can do with the model is, for example, here we've taken 1, 2, 3, 4 of these patient-derived xenograft models and then taken some patient samples and done some very short drug treatments on these in the laboratory. And I'll just highlight one class of medications that came up as interesting in leiomyosarcoma was a class called CDK or cyclin-dependent kinase inhibitors. And skipping forward to some of the outcomes, we took these xenograft models and grew them in mice and then treated them with a CDK inhibitor. This is the name of the preclinical drug. This isn't something that's given to patients yet. And the mice that were not treated with drug in the black line here had their xenografted tumors continue to grow on observation, but mice receiving the drug actually had their tumors stabilize or regress. And we were able to see that with several of the xenograft models that we looked at with the CDK7 inhibitors. And we think this is going to be, as clinical compounds are developed and brought into clinical trials, which they are now, this data advocates for leiomyosarcoma being included on the trials that are developing those compounds. So in summary to the presentation so far, there are several subtypes of gynecologic sarcomas. They have very different genetics, behavior. It's important to come to the right diagnosis to come up with a treatment plan. And that treatment plan will be based on the status of the disease, whether it's localized or metastatic, and then individualized discussions with a multidisciplinary team about how to treat with surgery, chemotherapy, radiation, et cetera. And there's active interest in studying these diseases, but that is rather challenging, in part because these diseases are rare. that laboratory models are uncommon or are not available for many of these sarcomas. And then funding for rare cancer research is also a major challenge. So with that presentation, we received many insightful, thoughtful questions, some of which I've summarized here. And Liza, you also have questions coming in on the chat or from others interested joining the webinar. Should I go ahead and address some of these one at a time?
Yeah, I think that'd be great. And please, if anyone has more questions as Dr. Hemming continues, please put them in the Q&A box and we will do our best to address as many of them as possible. Like Dr. Hemming said, these questions are kind of summaries because we had a lot of common themes with the pre-submitted questions. So if it's not exactly how your question was framed when you submitted it, know that we're trying our best to cover as many bases as possible with the time that we have. Go for it.
So for the top question we touched on already, the difference between a sarcoma and a carcinoma. Carcinomas are far and away more common than sarcomas. Sarcomas represent just 1% of all adult cancers. And it all comes from what is the cell and tissue that the cancer arose from. And sarcoma is generally coming from connective tissue, bone, muscle, are tissues that are much less proliferative. They don't grow and replace themselves like the lining of your intestine or your gynecologic tract do. So their risk of developing cancer is lower, presumably because they're not exposed to the outside world and they don't proliferate very much. And that is really the main distinguishing features. You'll also hear that sarcomas derive from mesenchymal origins, and that derives from the embryo and how we think about the three lines of differentiation within an embryo. Sarcomas come from mesenchymal tissues as opposed to epithelial tissues and brain tissues, which come from other embryologic origins. So the role of a liquid biopsy. So my group and others have identified that we can identify circulating tumor DNA in leiomyosarcoma. And some others have looked at it in many other cancers. And this is actually technology that grew out of prenatal diagnosis. So currently for a woman at high risk with a high risk pregnancy, they'll have a prenatal testing of their blood and you can find fetal DNA in the mother's blood. We can do the same thing for cancers and find shed DNA or sometimes RNA in the blood of patients with cancer and use that as a means of trying to detect cancer and detect specific mutations that might portend a specific therapy to treat the cancer. Currently, there's not a standardized role for liquid biopsy in any form of sarcoma. There are many preclinical laboratory corollary studies that have found that you can identify circulating tumor DNA, but it's not yet standard of care to test it and use testing to inform clinical decisions. In principle and in the future, as this technology becomes more sensitive and we hopefully will have more and more therapeutic options to treat patients with, a liquid biopsy will be an ideal way of doing it. Obviously, it's non-invasive or relatively non-invasive, and many of the important information about genetics or status of the tumor, in principle, you could find in the DNA rather than having to do a biopsy. But it's not yet standard of care to perform liquid biopsies in sarcoma.
Dr. Hemming, are there other things that people can do for detection before if a liquid biopsy is not something that is standard of practice with GYN sarcomas? Is there something else that people could do that maybe they would know, get a head start without having any symptoms or any problems?
Right, good question. And the standard would be to do imaging surveillance. And for patients who have resection of their disease, let's say, depending on the sarcoma subtype, there's a standardized method to perform surveillance looking for early recurrence. Obviously, the treatment approaches to a localized recurrence would be very different to a metastatic recurrence. So ideally, if a cancer were to come back, we'd find it very early. And the current guidelines for many sarcomas, for example, is after surgery to start doing surveillance with imaging at 3-month intervals for at least 2 years, and some it goes out to 5 years where it's at that frequent of interval. And typically that is imaging of the local site. So that would be in this case for a uterine leiomyosarcoma, we'd look within the pelvis looking for reoccurrence. and then looking for metastases. And for leiomyosarcoma, lungs would be most common. So we would look by a CT scan typically of the chest, abdomen, and pelvis, and those would be done initially at 3-month intervals, looking for early recurrence. And that would be standard of care of how we would do that now.
Thank you. It looks like you already knocked off one of the answers to one of the questions on this list with that answer.
And everything's clearly all related in overall care of these rare diseases.
Definitely.
So the patterns of sarcoma metastases, most commonly sarcomas spread through the blood. That's not true of everyone, but including the gynecologic sarcomas, that's the most common means of spread. And that means once they're in the blood, one of the first small capillaries that the tumors hit are in the lungs. So lung metastases are the most common. Outside the lung, liver is another common location. Local recurrence can occur anywhere that a cell gets left behind after surgery. Really, the only place that sarcomas tend not to spread to is the brain, and that's not 100% true. You can get brain metastases from gynecologic sarcomas, but that's an uncommon place where it would occur. And this goes back to the question of where do we do surveillance for? And typically that's chest, abdomen, and pelvis. And it would only be if someone has a symptom or a concerning finding, say in their subcutaneous tissue on an extremity, or some new neurologic symptom that we would look elsewhere. But certainly if any symptoms or concerning findings come up, alert your oncologist right away, and that would prompt further investigation. There was a question on looking at homologous recombination deficiency and PARP inhibitors. And this is something that has come to an interest mostly in uterine leiomyosarcoma. Homologous recombination is a defect within the cancer cell, for example, from a loss of a BRCA gene, that impairs the cell's ability to heal its DNA. And there are drugs that can be effective when a cancer cell has that defect that block it from healing the DNA by other strategies. It's not something that is currently by guidelines tested for, but there are clinical trials suggesting that HR deficiency is a vulnerability in leiomyosarcoma to PARP inhibitors. There have been clinical trials that have looked specifically at this, and there are others being developed in the future. So this may be something that will be routinely tested in the future and a therapeutic opportunity or option for people that have HR deficiency. Especially for people with a strong family history of cancer, that should prompt a referral to genetic counseling and looking for things like the BRCA gene. And if someone with a known BRCA mutation were to develop a sarcoma, we would think about their disease a little bit differently than for someone that didn't have that strong family history. As a follow-up to that question, I'm going to step on a later question, is that sarcomas can be hereditary. Typically, the translocation-associated sarcomas are not hereditary, and that arises in the individual, and family members are not at increased risk because that's an accident of nature that happens in someone's own body. But other forms of sarcoma, like leiomyosarcoma, can be inherited, and there are syndromes like Li-Fraumeni syndrome, retinoblastoma, or BRCA alterations that can lead to an increased risk of sarcoma in that individual and the family members. So a sarcoma diagnosis should prompt consideration of a referral for genetic counseling for everyone. So questions about imaging strategies for diagnosis. And we talked about imaging for surveillance, but imaging for diagnosis, that may depend on the location of where the tumor is and the initial symptoms that led to the evaluation. So a CT or an MRI are often primary approaches to getting the initial imaging of the site of tumor or symptoms. There are other specialized testing. There was a question about 3D ultrasound, and I don't have too much experience or think that that's a commonly used approach currently for sarcoma diagnoses. But PET CT imaging can be used to look at metabolic activity. That's not a standard way to work up gynecologic sarcoma initially. So CT or MRI would be my standard approach. With discussion with radiology if they think any other advanced imaging technique would be helpful in better defining the tumor and helping facilitate future biopsy of the tumor.
Perfect.
What can be done to decrease the risk of recurrence after surgery? And that's a question that everyone asks after their surgery, and it's very difficult to answer. For some sarcomas, we do think about administering chemotherapy and or radiation after surgery, sometimes before surgery. And that's often a very individualized discussion. The clinical trial data on looking at the use of chemotherapy to decrease the recurrence in sarcoma is not as strong as in other cancers. And it is a select patient that has a high risk disease where we would recommend using it. The traditional treatment would be high doses of very toxic chemotherapy, doxorubicin and ifosfamide for most forms of sarcoma. There's some newer evidence saying that an immune-based therapy, pembrolizumab, may also decrease the risk of recurrence, but that is not yet globally standardized and is still under investigation. Beyond other therapies like chemotherapy and radiation, there's plenty of evidence to say that the healthier you are and taking care of yourself, both with a good diet, exercise, community, that will improve your outcomes with cancer if the cancer were to come back. And that might work by several factors. It helps your body to tolerate future treatments. It's not clear that any of those decrease the cancer from coming back, but if it were, you would be in a better position to pursue aggressive treatment of your cancer.
Dr.
Yeah,
I
please.
want to jump off these questions because I feel like you've overlapped a bit. And so
Yes,
I'm hoping that we can jump into some of the other questions that were
great.
submitted. I think a great one is there a specific doctor that should be seeing patients with sarcoma diagnoses? Is a GYN oncologist a good fit, or should someone be seeking out a med onc who specializes in sarcoma?
Good question. And there are a lot of gray lines in gynecologic sarcomas about who is best to manage them, and that varies by institution. Some institutions, if there's a sarcoma diagnosis, they'll be firmly planted in the sarcoma clinic. And in others, the gynecologic oncologist will be the one to primarily manage them. So I think at your institution, whoever has the most experience and with that institutional memory of managing those specific sarcomas, it's the experience and expertise that you want to pursue, and not necessarily the hat that they wear, whether they're a sarcoma medical oncologist or a gynecologic oncologist. So having confidence in a good relationship and knowing that there's expertise in your provider, no matter which hat they wear, is the important part there.
Perfect. I'm going to combine two of the questions that were submitted through the chat because they seem like they could be related. Is there a way to distinguish between fibroids and leiomyosarcoma? And is that something that makes diagnosing it challenging because they can sometimes be similar?
Yes, excellent question. And that is a common challenge and pitfall with imaging is distinguishing a fibroid from a leiomyosarcoma. So I'm confident saying that we don't have a perfect test to know whether a uterine mass is a leiomyosarcoma or a leiomyoma. Certainly, leiomyomas are much more common than leiomyosarcomas are. And there are several strategies that are investigationally used trying to better stratify them. And one is by imaging, primarily with MRI, and using MRI and radiometrics tools to better distinguish leiomyoma from leiomyosarcoma, but still very challenging. And another strategy would be to use something like a liquid biopsy or circulating tumor DNA, where leiomyosarcoma and leiomyoma do have different features. So that is an unfortunate challenge that there's not a good answer to. And for me as a sarcoma medical oncologist, if there is a mass in the uterus, of course, sarcomas and leiomyosarcoma is my first thought, though that would be much less common, far rarer than leiomyoma.
Got it. Okay. I'm going to ask another question from the chat. Can you discuss aromatase inhibitors for uterine leiomyosarcoma or GYN sarcomas in general?
Yes, for leiomyosarcoma, there are a subtype of leiomyosarcoma that expresses the estrogen and progesterone receptors. And that has led to an interest in using aromatase inhibitors as therapy for these forms of sarcoma. The clinical trials looking at them are suggesting that it could be a positive result, meaning that aromatase inhibitors may help. However, they're small trials, and we think that the biology deriving the ER positive leiomyosarcomas portends a more indolent course than other forms of leiomyosarcoma. So I think we don't have the right answer of how much do aromatase inhibitors help. Certainly, if the tumor has a strong ER positivity, that would be something to consider. And there are ongoing clinical trials to better look at that for leiomyosarcoma. For other forms of sarcoma, like low-grade endometrial stromal sarcoma, that does have a much more firmly understood benefit for using aromatase inhibitors in low-grade endometrial stromal sarcoma. So that would be a standard therapy, whereas for leiomyosarcoma, it may be a treatment option to consider, but the evidence of benefit isn't as certain.
Perfect. Another question submitted earlier was, do gynecologic sarcoma patients tend to see more chemotherapy than regular GYN patients? And is there a typical amount?
It's a good question, and I'm a little bit biased and uninformed since I've only done sarcoma for more than a decade at this point. So I haven't kept up with what's the current standard for GYN chemotherapy regimens. So that's in part my lack of knowledge on the current treatment strategies there. For sarcoma patients, I would say it is less universal to treat with chemotherapy after surgery because the absolute benefit isn't as certain as it is in GYN cancers and other forms of cancer. However, in the context of more advanced disease, where the disease is unresectable, chemotherapy would be the mainstay of treatment, with other supportive treatments such as radiation, opportunistic surgery, and ablation, including other strategies. But chemotherapy would be the backbone of treatment for advanced disease. And often these patients will continue on chemotherapy for the rest of their treatment course. And as long as they want to continue to pursue cancer therapy, one form of chemotherapy or another, or a clinical trial or an immune-based therapy might be the recommended course. So it's hard to say pound for pound how much chemotherapy a sarcoma patient gets versus a ovarian cancer patient. But it really depends on the individual. And for advanced disease, chemotherapy would be the mainstay for both.
Perfect. Okay. You talked about this a little bit with the connection to hereditary cancer, but are genetic markers and biomarker testing helpful to do more targeted treatment for GYN sarcomas?
There are some indicators for molecular testing that would recommend more targeted therapies. So if there's homologous recombination defects, that would um, raise, as I'd mentioned earlier, the use of PARP inhibitors for that particular tumor. There are other rare alterations that you can find in leiomyosarcoma, for example, an ALK translocation. And we do have ALK-directed therapies like crizotinib that can be very effective in that disease. Though it's not currently standard of care for sarcomas, doing global molecular profiling, and many hospitals do this. There's also many companies that do this molecular profiling. They'll look at the sequence of roughly 500 cancer-associated genes and also look for various translocations and potentially could find an alteration in your tumor that would recommend use of a more targeted therapy. So that rarely can be helpful in sarcoma. Something else that testing can do is estimate the tumor's mutational burden. And if the mutational burden is high, then that would recommend the use of immune-based therapies like immune checkpoint inhibitors. It is rare to have a sarcoma with a high mutational burden as opposed to a carcinoma. So that all these factors have led to the current standard of not pursuing molecular testing for every patient at diagnosis, and it's not currently standard of care. But hopefully in the future, as we have more information, more therapies, and the cost of this testing goes down, it's something that will be available to everyone, anticipating that it would help direct treatment.
Right. Okay. There's a question in the chat that goes with one that was earlier submitted. How fast do sarcomas grow? Is there a typical rate for sarcomas?
And that can be quite variable. And I highlighted with the different subtypes that some are inherently more aggressive than others, such as high grade versus low grade endometrial stromal sarcoma. But just looking within leiomyosarcoma, for example, there's quite a variability. And some tumors can be very indolent, while others can be very aggressive and very prone to spread. And it's hard to know that upfront. You can, after initial resection of localized disease, you can give a grade and a stage, and that will give some prognostic information. But without the perfect ability to give a prognosis, doing close surveillance is the best strategy so that if you do see an early recurrence or growth of something small that was initially indeterminate on imaging into something that's more concerning, you'll find that as soon as possible. So there's a lot of variability in biology between even one subtype of sarcoma.
Okay. You covered this a little bit at the end of your presentation, but can you tell us more about research and clinical trial strategies that are being worked on right now to push forward progress for these diagnoses?
Yeah, there's a strong interest among us few people that are passionate about sarcomas to pursue basic and translational research. And what that would entail is doing studies of samples taken from surgical specimens, developing models in the laboratory that you can do experiments with, and coming up with new treatment strategies that you could then motivate to use in a clinical trial to offer something that you would combine with standard of care or if there is no standard of care, is the only therapy for your patient. So there's certainly a lot of need and a lot of interest in doing research in sarcomas, and that's what my lab is devoted to. I would say that it is very challenging to get funding support for rare cancer research, especially in our current climate. And that is something that has slowed the development of new therapies for sarcoma compared to virtually every other form of cancer.
Okay, thank you. I'm going to jump back to your list and the summation of the questions submitted before. Can you tell us more about the role of immune and cell-based therapies?
Yes. So immune checkpoint inhibitors that are advertised on TV and that many people with other cancers get have revolutionized the treatment of many forms of cancer. They have not had a strong impact writ large across sarcomas. There's only one sarcoma subtype that has a formal approval to use an immune-based therapy, and that's alveolar soft part sarcoma. It has been tested in many different studies across many subtypes of sarcoma, and just highlighting leiomyosarcoma, there's not a clear evidence of benefit of immune checkpoint inhibitors in most patients with leiomyosarcoma. So unfortunately, it hasn't had the positive impact across sarcoma that it has in other forms of cancer. And it's hard to know exactly why, and there's a lot of research being done to try and understand this. It seems like, for example, sarcomas have a lower mutational burden, as I'd mentioned earlier, and that's something that the immune system can utilize to recognize that the cells are abnormal. And that might be one reason why sarcomas are more resistant. But they also interact with the immune system in different ways than do carcinomas. And finding out new and better ways of targeting sarcomas to be recognized by the immune system is a real need for these diseases. For cell-based therapies, there are a few different strategies that have evolved for treatment with cell-based therapies, and that's either taking a patient's cells out of them and activating them in the laboratory and then delivering them back to a patient, or it would be engineering a cell like a T cell. So, for example, a CAR T cell would take an immune cell, a T cell, out of a patient's body, engineer it to give it a specific receptor, and then deliver it back to the patient and have that receptor recognize the cancer. And that has been an effective therapy for many types of leukemias and multiple myeloma. And there is one sarcoma, synovial sarcoma, that does have a cell-based therapy approved. That was the first approval for a solid tumor. It has not yet found traction within the gynecologic sarcoma space. And part of the challenge is finding one protein that's universally expressed on your cancer, but is not expressed in normal tissue. So I think it's a combination of a lack of active research in this area due to the rarity of these diseases and lack of funding to support it, and lack of models, but also that it is not yet clear that these forms of sarcoma express the same recurrent proteins that aren't present in other parts of the body, like the B cell and myeloma cells do that are the current targets of cell-based therapies.
Got it. Perfect. Okay. Um, we still are getting some questions about carcinosarcoma. I'm going to try to make them a little more general and more related to sarcoma as best I can, knowing that that's not your expertise and maybe a GYN oncologist is the person to talk to. But you said that they were once established as a sarcoma, but now have moved more away from that. When did that happen and how? What's the relationship between the carcinoma and sarcoma, and when did that change happen?
Yeah, good question. I don't know the timeline of when that strategy changed. And part of it may be driven, one, by pathology and having the experts in making the diagnosis see clear differences between them and sarcomas. But probably what's more important is that the treatments that are more effective are the same ones that are used for other gynecologic carcinomas. And there's less effectiveness of sarcoma regimens. So I think that the clinical outcomes from using sarcoma regimens being inferior for carcinosarcoma and those of other gynecologic carcinomas being more effective have helped to usher in carcinosarcomas as under the umbrella of gynecologic carcinomas rather than sarcomas. And again, since they're managed by chemotherapy regimens that I don't prescribe, I typically don't see these patients, and they're managed by my gynecologic oncology colleagues.
Okay, perfect. Um, we got a few different versions of this question submitted earlier, and I know that you a little bit went over it as you went through each diagnosis, but is there ever a cure for GYN sarcomas, or for the most part, are they considered to just be life extending and watch and wait kind of diseases?
Yeah, good question. And certainly the hope is initial surgery will cure patients. For aggressive diseases like leiomyosarcoma, for example, that's not always the case. And we looked at the 5-year survival outcomes from the American Cancer Society saying that even with localized disease, aggressive sarcomas do have a high risk of recurrence and taking a patient's life. So certainly the hope is initial surgery, possibly with chemotherapy and radiation around surgery, can be curative. That's especially with aggressive disease. We don't just put everything onto hope. We do active surveillance to do early imaging to look for any evidence of local or distant recurrence so that we could start treating it as soon as possible. And if there is, for example, a local recurrence or they're spread just to one site in the lung or the liver, then it would be reasonable to consider another effort at curative surgery, possibly with radiation and chemotherapy before and after surgery, to get out all the disease we can see and effect a cure. So for patients that have localized disease and are surgical candidates, certainly the goal is cure. For patients that have more advanced disease that a surgeon's knife can't remove, chemotherapy typically won't cure those diseases. And we view chemotherapy as a way to control the disease. And for some people, that can be for a long time, and to allay symptoms that the cancer might be causing.
Perfect. Okay. There's a question that came in through the chat do you know of other programs that people can attend to learn more about GYN sarcomas? Do you host things through your clinic or otherwise?
There are other foundations, for example, the National Leiomyosarcoma Foundation, that I'm on their executive board, and they work hard to have a patient-facing side as well as a research side that interface with patients and share information. And I've done webinars there as well. For anyone interested in connecting with me, my email was at the top of the page, and I'm happy to follow up. We do have an active clinic here. Many hospitals will have a patient day. I've had many patients come in and visit my lab, for example, and see the research that we're doing on the sarcoma that they have. So there certainly are organizations like OCRA and other foundations that focus specifically on sarcoma and have events for sarcoma patients. And many hospitals either partner with foundations or independently have their own informational days to talk about treatment or research in a specific disease.
Thank you. And hopefully OCRA will continue to have more programming about GYN sarcoma. So keep your eyes peeled. There's a question that came in through the chat about something called the Count Me In project. Do you know about it? And is your team involved in it?
Yes, so Count Me In was an effort led by the Broad Institute in Cambridge that initially started, I think it was angiosarcoma, looking at collecting patient information and patient samples and doing broad genetic testing of the tumor and trying to glean, are there aspects of tumor biology that might have impacted the course of disease, and trying to come up with new understandings and treatment approaches. The Count Me In project was extended to leiomyosarcoma. I believe they have completed their enrollment and are actively doing research on what they've collected. I don't think there are any preliminary outcomes that have been reported yet, but I have had patients that enrolled in Count Me In, but I haven't heard any results from leiomyosarcoma just yet.
Got it. Okay, perfect. I think that we're just about out of time. So I want to thank you so much, Dr. Hemming, for taking the time to do this. I also want to remind anyone who is a patient or loved one that we have the next round of our endometrial uterine cancer 101 workshops that are starting on Monday. There's a link in the chat that I will put again to make sure that if you're interested in signing up for that, we'd love to have you. Again, thank you so much. This webinar is being recorded, and so it will be posted on our website and on YouTube soon. So if you want to go over all of Dr. Hemming's slides a few more times or review the information as well as get his contact information, it'll be available there. Thank you so much, and I hope all of you have a great rest of your day. Thank you again, Dr. Hemming, for taking the time to spend with us today.
Pleasure. Thank you for the opportunity. Thanks.